welcome to the UBC Learning Circle. Good morning. To those of you returning to the circle, welcome back. And to those of you joining us for the first time, welcome to the circle, hosted by the Center for Excellence in Indigenous Health. To kick off our first session of the fall, I would like to welcome Colleen Stewart, Jessica Ludwig, right? Pronunciation, and Denise Wallace to talk to us all today about Aboriginal patient navigators. Before we begin, I would like to acknowledge that we are on the traditional, ancestral, unceded, and occupied territories of the Hunkaminam-speaking Musqueam people. I would also like to acknowledge the First Nations Health Authority for generously funding the UBC Learning Circle. As a quick reminder to everyone participating today, I think particularly as we get into some of the Q&A, the topics we cover can sometimes be sensitive or emotionally triggering. If that's you, please engage in some self-care. Talk to a friend, an elder, counselor, whatever it is that you need to engage in that self-care. I urge you to do so. So quick introductions before we launch into it. My name is Cole. I'm from the Chawatho First Nation, and I'll be facilitating the session today. The other Learning Circle team member in the room, but off camera, is Cynthia, our production coordinator. For those of you on Zoom, if you feel so inclined, please introduce yourselves in the chat box. So I'll ask each of you to introduce yourselves, and we'll go from there. Colleen, can we start with you?
Sure. So my name is Colleen Stewart, and I am from the Squaw First Nation in Chilliwack. And as I often tell people in our presentations, I did not grow up on reserve. I grew up in Vancouver.
Hi, good morning. I'm Jessica Lutwick, similar.
Okay.
Jessica Lutwick. I'm from the Statliam Nation. I'm also a proud mother of one. I have a wonderful daughter named Phoenix, and I'm happy to be here today.
Good morning. My name's Denny Wallace. Like Colleen, I was born and raised in Vancouver, but my First Nation is Liwat Nation, and we are part of Statliam.
There we go. Cool. Okay, so I guess we'll just jump into it. I'll let you take us off here, Colleen.
Sure. So we'll just start our presentation. So, who would like to do the land acknowledgement? And now that Cole's done it.
So, thank you, Cole, for recognizing the Musqueam First Nations for allowing us to live, work, and play in their territory, as well as the Squamish and the Tsleil-Waututh. And so traditional land acknowledgement is becoming more and more of a way to begin meetings especially within our health authority. And so before we start meetings, we like to do a traditional land acknowledgement.
So we commonly will use this slide, and we will say, I would like to acknowledge the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations. And we include all of those nations because those are the territories that Vancouver Coastal Health covers. So.
Sure. So you guys, our intentions for today, we've got a few lined up here, is to review the Aboriginal patient navigator's role and the services that we provide. Our role has evolved quite a bit since I've begun. Provide a brief history of Aboriginal experience in healthcare in Canada. Review what culturally safe care could look like for an Indigenous patient, and answer any and all of your questions.
So Jess, I think
I can do this one as well. So I've been on board now as a patient navigator for over 6 years now. So I've seen our program evolve and change quite a bit. Originally, we provided about over 18 interventions for our patients. And it was too much. I mean, we worked within the hospital and also within the community. And it was hard to sustain because there's only 3 of us. I think at the time, maybe 4, but it's still quite a bit to cover all of coastal health. So we had a revisioning statement. A revisioning session, would you say?
Yeah, sure. I mean, most of those 18 interventions involved community care, and so what we had felt in our revisioning session was that we had to reduce our interventions list from 18 to 5 because we found that there were a lot of First Nations community members entering into the acute site, being admitted and being discharged without having seen or received support services from a patient navigator.
Mm-hmm. So during our revisioning, we came up with with our vision statement up there, which you guys can probably just read, and we went from 18 interventions down to 5. So we now focus on cultural safety and education, healthcare and case planning. So we work with the staff as well as patients to create a care plan for them. Referrals, so resources and referrals to Indigenous specific resources. And also we only work strictly within the hospital now. We do no longer work in community, but because we're very knowledgeable though about what is out there within the community, so we're still part of discharge planning when it comes to patients. We also provide health literacy and advocacy, and traditional and cultural supports is a big component to our program now.
Mm-hmm.
So, sorry, if I may just jump
Yeah,
in with a
absolutely.
quick question. I imagine that part of that kind of revisioning that you were talking about would have involved kind of those services that were no longer a part of your vision. Kind of what happened to them, to all of those kind of services or all those kind of programs that were happening at the time. Like if there's 18 things you were working on, right? I believe it was 18. You said right?
Roughly 18-ish, yeah.
And we bring it back down to 5. What happened to the rest of it?
To the other ones,
Yeah.
Well. Unfortunately, we got moved from community to strictly acute base, so our focus is now hospital as well as working with the staff. It's a little bit of a tough one, actually, as far as community. I mean, we are resourceful, like, with what's out there, so we just became more knowledgeable about what's within the community, and we just refer out now to other agencies.
Right, okay.
Yeah.
So a lot of that work went to individual, I guess, communities or other organizations or within the VCH and other kind of teams, I suppose.
Like in Vancouver, we'll rely on a primary care service like Luma Medical, which has, but in order to access service at Luma Medical, you have to have a primary care doctor or a nurse practitioner, but they have like an elder, they have a social navigator, a couple of doctors, an NP, they have elder service. And so what we end up doing is reaching out to the community services. So to be honest, things do get quite stretched. It can be a challenge to find service for people, but that's part of our work, is to see what we can come up with. Yeah,
totally.
We have to be resourceful.
Yeah. I didn't mean that to come across as critical at all, because I know that we're all very stretched, and
it's the reality.
It is, totally.
Yeah.
Well, one thing I did want to add as well, like we found there was a big focus because we were doing a lot of patient transportation and accompaniments, and that took up a lot of our time, and a lot of kind of more outreachy things, like people would ask us if we could, like, an elder take them grocery shopping, which is a very important thing for them, but that was a bit out of our scope about what we really wanted to focus on. So we were doing a lot of like driving around and bringing to appointments, different things like that. So there are other services for that too. So we just now we would refer out to other organizations.
Yeah.
And so part of that piece is because I've worked in both Indigenous and non-Indigenous aspects of healthcare, and the non-Indigenous population also needs that kind of service of medical accompaniment, appointments, and it's certainly a need. But filling that need can be a challenge. So sometimes we have to look for volunteers. We have to really work hard at trying to make connections out there. So yes, it's not always that easy, but
yeah, totally.
But we work with what we have, I guess.
Yeah, great, thanks.
Did you have any thoughts about that, Denny?
No, I think you guys covered it really well.
Okay. Okay, so the roles and services. So I am actually the newest Aboriginal patient navigator on the team. I've been with the team for about a year and a half, and I have come on as a new navigator with the new mandate. And so in some ways for me, it's a little bit easier because we want to be able to provide service in the community, and I didn't have to make that transition, so it is a little bit easier for me. And so for this slide, our role has evolved from providing the direct support to patients in community to coaching and mentoring the staff on culturally safe care while continuing to support patients in acute settings. And so what we provide is consultation with healthcare staff on healthcare planning for patients and cultural safety education, resource contact information, which we've already alluded to, traditional cultural support such as a smudging or other cleansing and purification ceremony, and traditional medicine. So I wonder if we as the APNs can just have a conversation about the consultation with healthcare and staff.
Sure, yeah.
Because I think it would be helpful probably for our audience to know what that means and how you can access us. Yeah.
Sure.
Any
Yeah,
thoughts?
what does that actually look like on the ground?
Mm-hmm.
Well, we do different things. I mean, for example, I just did a presentation, well, Denny and I did a presentation, I believe it was just on Monday, to the OTs and PTs, so occupational therapists and the physiotherapists, and we presented on our role.
Mhm.
And we did it in the form of a lunch and learn, because in an acute setting, they don't have a lot of time. We can't pull them off the units and speak to them for an hour. So we utilized their lunch hours. Everybody brought their lunch in, sat in a room, and then we did this exact same presentation for them.
There you go.
And just so educating them, so then they had the opportunity. We weren't pulling them off the unit and taking away from their work. They're having their lunch, they're learning with us, and they have chances to ask us. A lot of them are new hires too, I believe, so they can ask us questions about how can we access you, what is appropriate, and it generated a really good conversation, and our 1 hour flew by.
Right.
I guess another piece too is we are now part of the regional orientation at VGH and Richmond and Lionsgate. So for all the new hires, again, it's like a condensed version actually of this.
Okay.
So we're part of their orientation, so we get them as soon as they begin.
Right on.
Mhm.
Cool.
Sorry, Denny, were you gonna? Did you have a thought?
Did you want me to add on to that?
Please. Yeah.
It's very important to speak to staff about when First Nations are admitted into acute sites, is that they have the opportunity to receive traditional cultural support.
Mm-hmm.
That's one of the it's not the most important, but it is an important piece of First Nations Métis or Inuit person's care, is to include within their traditional practices and
Mm-hmm.
into our healthcare. Yeah.
So your guys' role in that would be you would advocate for the utilization of traditional medicines within the acute care setting, or kind of how does that work?
So Vancouver Coastal Health has an Indigenous cultural safety policy, which we will be talking about in an upcoming slide.
Am I jumping ahead? We can
Oh,
totally
that's
do
okay.
that.
No,
It's okay.
it's okay. It's
All right.
fitting for here too.
Yeah.
And that policy actually allows us to practice traditional medicine on site. And so the other piece is that sometimes we as APNs might provide a smudging ceremony or a cedar brush down, and sometimes we ask elders to come in and do that. It depends on the situation.
Mm-hmm. And I guess you guys have, some elders as contacts, I suppose, that you would utilize or that you would ask to come in and perform these services.
Yeah.
It's kind of like a.
In addition to the smudging, an elder will come in and provide a traditional prayer and song,
Mm-hmm.
and that's it's an important part of a person's healthcare, because it gives them the opportunity to be grounded, to know that their identity is recognized, and in a setting, in an acute setting, that's important.
Mm-hmm.
Yeah.
Not to mention that it obviously provides a strong sense of validity to our traditional medicine practices within healthcare settings. The work that you guys do is kind of pioneering that and pushing it forward and making sure that, our medicines are recognized in these settings, right?
Yes.
Absolutely. And as far as, and speak to the elders, actually, we have a whole list of elders that have gone through a bit of a screening process, because they are technically working for VCH, and they are going into the hospitals, they are having direct patient contact. So we have a whole list that are from different communities, different nations, speak different languages, and as elders, they each carry specific gifts. So when we get an elder request for a patient, we like to have a consult first with the patient and or family, just to kind of see, because sometimes they'll have special requests, like either a cedar brush down, or maybe they want a Cree elder, for example. So we will pair the best elder with the patient, and we've got a huge list of elders that we can go to.
That obviously directly supports the elders themselves as well in the communities that they come from, which is really fantastic. Cool.
And so one thing about when you're talking about us asking elders to come on board, I think you had just mentioned something about, what segued us into this conversation. I can't remember exactly how you said it.
The segues us into chatting about
the elders. Yeah.
About the elders. I believe we were talking about, Denny mentioned that you guys bring traditional medicines, or do you advocate for traditional medicines?
Yes.
Into the space. I think that's what we were talking about, right?
Yes, that's right. Sorry.
That's okay.
Sorry, everybody. Bear with us. And the thing is like, say, Jessica and I will sometimes do a smudge ceremony on a unit with a patient who is asking for a smudge ceremony. And we have seen the difference that ceremony makes. That ceremony, just the burning of the medicine and just having the brush down, you can actually sometimes see a physical difference in that person. It just seems to take a load off of them. And that is important when you're in hospital, because it's, you know, when you're ill and you're in hospital, it can be a very difficult place to be. And that's what I have learned from providing this service, is that it actually does make a big difference to the patients when they're on the unit.
Yeah, of course.
I think, and to provide an example, actually, Colleen and I would come out here to this campus, I think maybe bi-weekly for me anyways, and we do a group smudging at the Purdy Pavilion. So those are long-term care residents, and we utilize the sacred space for that. And I think it's amazing just to see. I mean, that might be the biggest event of their week even. And just that, you know, to have these Indigenous patients accessing their medicines and their traditions, you can literally see the difference it makes with them.
Yeah, totally.
So that is in our role as patient navigators, that's what brings value to the role, because we know that we're bringing traditional medicine to our patients and it's making a big difference.
Great.
Yeah. So, okay. So, I don't know.
I could start to speak to this
Sure.
one. So we quite get, I mean, because in our role, we're Aboriginal patient navigators, but you also hear the term Indigenous, First Nations, Inuit, Métis. So you hear all these different terms and people are like, well, what is the correct term to use? So as far as we go with Aboriginal is an umbrella term that encompasses First Nations, Inuit, and Métis. And it's from the Canadian Constitution recognizes that as the 3 distinct groups. And then Indigenous is kind of more, you've been hearing a little bit more often now, and Indigenous can speak to a lot of different things. Colleen, I don't know if you wanted to elaborate on the Indigenous piece?
Yeah, so we get this question often in acute care. I think probably almost daily staff ask us, because the staff are wanting to be respectful and they're not wanting to offend their patients. So they ask us, what should I say? We hear all these different terms. So Indigenous literally means native to the area. And so like I was saying in our staff meeting this week, you can be from Sweden and you can be Indigenous. So saying Indigenous is a very safe term. It's probably the most politically correct term right now. What we often talk about as Indigenous people is these are not labels that we have given to ourselves. And so we're not, like Aboriginal, First Nations, Inuit, and Métis, those are all constructed by the federal government, and those are labels that have been put on us. They have not come from us. But when we are working as Indigenous people in a non-Indigenous setting, we use the word Indigenous. So, Denny, did you have any thoughts about that?
It's important to remember too that the person who's identifying themselves can identify themselves, in the most comfortable way that they want to, right? So they're able to determine who they are.
Yes.
And ask the person, who are you?
Yes.
What do you prefer to be referred to as?
Yeah.
That's right.
Myself, First Nations.
Oh, okay. See, I didn't even know that about Denny.
There you go. Yeah.
So that's the thing, is when we are working with patients to create safety for those patients, we do ask them, what would you like? How would you like us to refer to you or your people group? Yeah. So, okay. Over to you, Denny.
Okay,
Your
so
favorite slide.
actually, Cole, the viewers can see the slides.
Yes, they can.
Okay, so the slide we're showing right now is reasons for health disparities. And because of colonialism and racism, Indigenous people experience a lower quality of life compared to other Canadians when measured against the United Nations Human Development Indicators. And as you can see there, in all the 4 sectors shown, in education, labor force, income, and in housing. What was it?
It's housing, yeah.
It's housing, yes. Yeah. So we measure quite low in terms of in disparities. And so if we really understand and use those measurements, we understand that, we, as First Nations people, Métis or Inuit, we rank quite lower.
With the knowledge that all of these these are all determinants of health. What we mean when we say determinants is that they contribute to one's experience as they access healthcare and their general health as they progress forward due to a variety of factors. Am I getting that right?
Yes.
Yeah.
Yes.
Okay.
Yeah. And I would call those the social determinants of health.
There you go. Social determinants.
Because I'm a social worker. And
There you
that's
go.
always important to me. And it's really incredible when we work with Indigenous patients, how much those social determinants of health really impact them. I was working with a patient yesterday on a unit, and her life is really riddled with poverty and a lack of resources and healthcare struggles. And so this was, it impacts me personally as an Indigenous woman to see our people struggling. And fortunately, I was able to debrief with Jess about this patient and my concerns with her. And so those are the kinds of struggles that Indigenous people face and what we're working with when we're on the units. It's these actual disparities. They're not just numbers on a graph. We work with these people day to day. Yeah.
And I just wanted to speak to that a little bit further. Just I'm looking at there when it says literally says gap, and the point of one of the major points of our program is to close that gap. That is why Aboriginal health is here.
Yes. Yes, that's right. Yeah. And I would like to also just comment on the resilience of the patient that I was working with. The things, I have to respect her confidentiality, so I'm not going to give details about her, but the things that she's given me as examples of her resilience, of her strength, of her ability to survive, her resourcefulness, those were all incredible strengths that we work with. But it is definitely those gaps that we're trying to narrow.
I really appreciate that, Colleen. I think a lot of the times when we engage in these conversations, particularly as it relates to health disparity or labeled as health disparities, we can get in this really negative mindset when it comes to the way that we approach the health of Indigenous people. So I really appreciate you pointing out that strength, because if we come at it from a strength-based perspective, that's not diminishing these very obvious health disparities that do exist, but kind of balancing them with recognizing the strengths that all of us as Indigenous people have and the communities that we live in are strong.
Yes.
They have to have been strong, right? But how can we proceed forward with that strength in mind, as well as acknowledging these health disparities and how we close that, right? So thank you very much for bringing up that piece.
You're more than welcome. Any other thoughts?
No.
Okay. So this graph, I guess these images are just identifying what those health disparities are. Were you going to say something, Denny? No?
No, yeah. I mean, if we look in the center, we look at the health impacts of colonialism, and in every other
category.
In every other category, we seem to be higher than the mainstream population, and those are direct impacts of colonialism. And so, as Aboriginal patient navigators working in the healthcare system here in Vancouver Coastal Health, we would help healthcare service providers identify that who are you providing care for, and to understand that you come from a different perspective.
And I think that's a really good point, Denny, because we cannot deny the impact of colonialism, and maybe there are people out there who don't know much about colonialism. But I mean, we work with residential school survivors, survivors from the foster care system, people who have been deeply impacted by colonialist history and policies of the past. And our work through Vancouver Coastal Health is really striving to decolonize those systems so that our people can become healthy. And that's the work that we do as APNs.
Yeah.
Yeah,
Really kind of standing in the middle between the patients and these healthcare structures
that's
that
right.
exist
Absolutely.
and bridging that.
Exactly. Bridging that and also to close those disparity gaps.
Mm-hmm.
And I would say with Vancouver Coastal Health and the ICS policy that we have, and our wonderful team at Aboriginal Health, we do have support.
Mm-hmm.
And a lot of our work is also about bringing awareness. So, yeah.
Great.
Okay.
I can speak to some of
Sure,
this, or at least
sure.
I can get it
Yeah.
started.
Okay.
So we're going to talk about key concepts to provide culturally safe care. So I'm sure you probably heard a lot of the terms these top three. We've got cultural humility, cultural safety, and cultural competency. And some people kind of wonder, well, what do they all mean? So I can start with cultural humility. It's a constant self-reflection. So you can't just kind of check a box and say, I have cultural humility. Like it's a lifelong thing.
Mm-hmm.
And it's acknowledgement of personal and systemic biases and power imbalances.
Mm-hmm.
So it's these concepts that we're introducing into the healthcare providers
Right. Right.
within the acute sites.
Okay.
And so the Aboriginal Health for Vancouver Coastal Health is providing workshops for units and healthcare staff to come to understand who First Nations, Métis, and Inuit people are.
Mm-hmm.
And it's a 3.5-hour course. And the concepts that we cover is cultural humility, cultural safety, and cultural competency.
Sorry. And now, just a question I have on that: is there any sort of is there any mandate for acute care physicians to engage in that course, or is this something that they're electing to pursue? Do you know what I mean? Like, is it coming down? Is it back? Is VCH saying all acute care physicians have to have this course to be considered? Do you know what I'm getting at?
There is a policy put in place, a cultural safety policy, that was signed off by the COO. Is it COO? CEO, Mary Ackenhausen, and she signed off on the cultural safety policy.
Okay.
So that first healthcare providers would have to come to gain knowledge about who they're providing care for when they're providing care for First Nations, Métis, or Inuit.
Mm-hmm.
So right now it's not mandatory yet for them to take it. It is being offered, but there's certainly a lot of interest in it right now. I mean, there are a lot of people who've already taken it, and I believe there's a bit of a wait list for the new people. So not quite yet is it mandatory, but it's certainly stirring a lot of interest, and a lot of people have already taken it. I don't have the exact numbers right now, but.
And so this training is provided usually at our Aboriginal health offices, and quite often we have teams or groups of people who come from the same team take the training all together. And so I know that there have been a number of physicians who have gone through that training, and most of these people are electing to take the training. So, when you make something mandatory, it can get a bit like I have to take this training, but when people are volunteering and electing to come, then you know that the interest is there, their heart is to learn more about Indigenous culture and cultural practices within the healthcare system.
So with obviously, I assume the end goal being that, we generate the interest and, if physicians are going and participating in this, in your course, and I imagine other medical professionals too,
yes.
I'm just saying physicians broadly, but, so that they then go back and report to their peers about how much of a difference that training makes to them in their practice.
Yes.
And hopefully kind of generating interest in that way.
That's right.
Correct? Yeah.
Yes.
That's kind of what we're shooting for? Okay.
Yeah.
Great.
And then we do sometimes notice a bit of a difference between people who have taken this, what we call ICS training or Indigenous cultural safety training, and those who have not. And so that training really provides a context of Indigenous history and the impact of colonialism on Indigenous people. And so it changes the lens of your practice a little bit, your paradigm shifts, so that when you have Indigenous people coming to access healthcare, there's a bit more of understanding of how this person may have gotten to where they are in their life. So.
And we as a team actually took the training before it got rolled out to the other staff. We as a team took it just so we could have a better understanding about what they will be learning and what they will be going through. So it It was interesting. I mean, I learned some stuff that I'm Indigenous,
Mhm.
but there's some things that I didn't even know.
Yeah.
So I mean, it's a constant learning process, I believe. But yeah, we came together as a team to do it, and I found it very impactful.
Great. We have a couple questions from the webinar, so we might just take a
Sure.
quick break and kind of
Yeah,
go over
sure.
there. Rebecca asked, is the training being referred to the same as the Sanyas training through PHSA? Do you guys know that, Sanyas?
Yes.
Well, the Sanyas is through the internet, right?
It's online.
It's online, so
Right.
it's not
Not in person.
it's not in person,
Mhm.
which is important.
Mhm.
It's totally different, I believe. And
So the Sanyas training is it's provided from a different health authority. So that's I think, is it PHSA?
Yes.
PHSA, and ours is through Vancouver Coastal Health. And there is, I mean, I have not taken the Sanyas training, but I have heard that it's kind of good foundational introduction
Good
to
place to start.
Yes, exactly. But with the in-person training, just having it in person. So the in-person training is not what I would call lecture style training. It's not an expert standing at the front lecturing at the audience. We actually sit in a circle. And then there's an opening circle. There's what we call a timeline, which gives an overview of pre-contact history with Indigenous people through contact and trying to force Indigenous people to assimilate and integrate into Western culture, and then up to present day, the effects of those colonialist policies on Indigenous people. So it's meant to be participatory. It's meant to come from the heart. Yeah.
And I find it impactful as well, because when you're online, you're by yourself on the computer, clicking away, reading. Whereas when you come together as a team and you're working together, learning together, I find it's a lot more meaningful that way, and a bit more impactful too.
Yes.
Yeah.
Versus click, because I think you read it kind of in one ear or the
It's
other.
easy to glaze, to kind of glaze out.
And if I can add too, I mean, it's recommended that when groups do the training, that they do it with their peers, with their colleagues within their unit. So
Right.
I mean, they come to understand the impacts of colonization on First Nations people together.
Mm-hmm.
Whereas when you're doing it, like I like the foundational training is great, I understand, but I feel that there's a lot more meaning in understanding who First Nations, Métis, and Inuit people are when you actually do the in-person training with your colleagues.
Yeah. Well, then you as a team are better suited, right? Whereas, or not better suited, sorry, but are better prepared, let's say, to engage with the Indigenous patients, as opposed to, just having one person from the team. That's not the goal. You know what I mean?
Right.
The goal would be that healthcare would be a safe place at all times, regardless of who you're talking to. Do you know what I mean? Whether or not it was the nurse, the physician, whatever. Do you know what I mean?
And so that links into our APN role, because when we go on to units where we know that the staff have had the ICS training, there's more of an understanding. They know who we are and they know why we're there, and it's a bit more engaging, I would say.
Mm-hmm.
Yeah.
So we'll take another couple questions.
Yeah, sure.
Benedict, did the patient feel listened to by healthcare professionals? Did the patient have their experience explained to them and have understanding? Maybe you guys understand. Benedict, if you could maybe just type in kind of what are you referring to after, kind of after they've received or the physicians have received the trainings? Is that a difference? You know what I mean? Or does anybody else? I've just struggled to understand the context of your question, Benedict.
Are you referring to a specific example that we've made, or are you thinking of patients generally? Yeah,
if you could just illustrate that in the chat box, and we'll jump back up to another question while we wait, and that is from Megan. There will be an upcoming provincial patient-reported experiences measures survey that will be measuring patient experiences as individuals transition across healthcare settings, so into emergency departments, acute care facilities, and discharged home. The survey will be collecting data over the next 2 years and includes a self-identification ethnicity question. Megan's question is, what do you think are the most important aspects of the patient experience that could be captured from the patient's perspective as they transition into and out of emergency departments, hospital, and going home? And then a follow-up, what are some of the main challenges you have seen as patients transition between these settings? So Big question.
That's
We'll go
a
back
good
up to the front. What do you think are the most important aspects of the patient experience that could be captured from their perspective as they transition from emergency departments and hospitals and into home?
Well, I guess sometimes when we get referrals or calls from the emergency department, one I don't want to say issue, but something that comes up frequently is that Indigenous people may not want to self-identify as Indigenous, and the staff sometimes don't know how to identify if somebody is or is not Indigenous. And so we have gentle questions that we would ask as APNs to make it safer for a patient to self-identify as Indigenous. I think the stigma that comes from stating that you are Indigenous, there's a fear that you might get treated differently. And so that is something that we see often. And having a box to self-identify whatever your ethnicity is, I don't know that necessarily an Indigenous patient would necessarily tick that box. What do you guys think?
It really kind of depends on, exactly, if you're comfortable identifying as Indigenous, because some people are, some people are not. So it's a really personal thing.
Yeah.
And even if you do identify as Indigenous, you may not want to participate in ceremony. You might identify as Indigenous, but I don't practice my culture, for example.
And we do get referrals like that as APNs, where sometimes a staff member with a good heart and good intentions and gets consent from the patient for an APN referral, and then that patient says, well, I don't really practice my culture, or they have some other belief that they follow. So that can be a challenge. Yeah.
Okay. So you guys, to kind of summarize, I guess you guys feel that the self-identification aspect and getting patients, I guess, to self-identify within the acute care setting might be kind of an area where there may be some barriers, or there may be some hard times kind of getting through that step. As Indigenous patients are all kind of, obviously we're all on the spectrum on how we feel as we access healthcare, and whether or not we want to be known as Indigenous patients, I suppose, right?
I'd almost say there could be two boxes. One, do you identify, and then two, would you like to maybe receive supports, or would you like to receive some Indigenous supports? So because you might identify, but you may not want to be connected to an Aboriginal patient navigator, for example.
Okay. So then, and a follow-up question: what are some of the main challenges you've seen as patients transition from these healthcare settings?
One I would say is taking into consideration. I was thinking when they're discharged, let's say they're going to a rural community,
from a hospital. Let's say. Okay,
So it's what kind of community supports are there? Where's the nearest clinic? Where's their pharmacy? Making sure all those little bits, like medication, supplies, are all kind of hooked up. Because in Vancouver, the pharmacy's just over there. But if you're in a rural community, it might be hours and hours away on a dirt road. So keeping in consideration where the patient is going and what services are local to them.
Yeah, that's a really good point. So that's kind of one of the big challenges you see, Jessica, as kind of patients transition out of these care settings into their home, can be based on where they're going.
Yes,
If
absolutely.
I can add to that too, is that it doesn't happen all the time, but sometimes patients are discharged without knowing what their plan is, their discharge summary plan, and it's important for them to understand that most times when you're discharged, you'd have to do a follow-up appointment with your primary care doctor, your family doctor, and so on, and just to understand if there's medications that they're taking, to do a follow-up and understanding how that medication is working for you. And so that's an important thing too. It's just not with medications; it's with rehabilitation. Maybe. Like Jessica was saying, that the patient doesn't have access to some of the supports that were recommended for them for therapy or whatever it is, and so it's just to address those points is important.
So you're saying lack of access, and sometimes maybe a lack of understanding as to what, or maybe it wasn't communicated effectively for some reason or another to patients as they transition out. Is that kind of what you're saying?
Mhm.
Okay.
Yeah.
Do you
Colleen,
mind
do you
just
have anything to
repeating that,
Sure,
that
yeah.
question?
So Megan's follow-up question, her first follow-up question, we're getting overwhelmed now. What are some of the main challenges you've seen as patients transition from healthcare settings? So coming from a hospital to home, or let's say from an emergency department to a long-term care facility or whatever it is, right?
Mhm. I mean, I have an example of a patient who came into hospital with cardiac symptoms, and she was asked several times about addictions, and she kept saying no, that she did not have what she was being asked about, and it became an issue for her because this was a person who actually had no addiction background. She legitimately had a cardiac issue event, and she needed care, and the person who was asking the questions kept saying, well, are you sure? And to the point where it got offensive and hurtful. And so that's the kind of thing, that's, I think, partly why Indigenous people just may not want to self-identify as Indigenous, because there are so many assumptions and stereotypes about lifestyle and all kinds of things. So that would certainly be a barrier.
And ultimately that impacts the quality of care that they receive,
Absolutely.
right? Especially in the event of a cardiac event, if you're wasting time repeatedly answering the question, every minute counts. You know what I mean?
So, and and we've had, I think we've worked with a few patients over, the year and a half that I've been here, who some of them are afraid to access healthcare. And it's not to paint like a completely negative picture of healthcare, because actually I think the healthcare professionals are doing a fantastic job, and we often get very good reports about from Indigenous people themselves saying, no, I've been treated with 5-star treatment here since I got here. So it's not to paint a completely negative picture, but it's to say, this is where the work needs to be done. This is why we need APNs, and we need that Indigenous cultural safety policy to be able to support our Indigenous patients.
And to continue.
Exactly, absolutely. To continue, to grow, to get stronger, provide better care. Yeah.
That's great feedback that you guys have been receiving. And I think that, on the surface, that's like fantastic, right? And my mind goes to, well, what about the patients that aren't accessing the care? That have those experiences? What about the patients that never, never get to the point where they're reporting feedback?
That's
Do you know what I mean? So to hear you say that feedback is fantastic is good. You know what I mean? Because that means that there's change that's happening here, and that hopefully over time, fewer and fewer people aren't going to be accessing the care, right? That silent population, that silent demographic that doesn't get represented in surveys is going to be diminishing. Do you know what I mean?
Absolutely.
Or I think that's the goal anyway, right?
Well, and so we, Jess and I had a patient that we worked with, and this patient actually ended up getting discharged from the unit that he was on, and he was really electing not to follow the treatment plan that was prescribed for him, and he left. And I was able to provide the unit educator with information on an Indigenous primary care, a new Indigenous primary care center in the downtown east side, which approaches healthcare from an Indigenous, like a medicine wheel perspective, where all 4 quadrants are honored. And my hope for that patient was that if he could access that service, maybe he wasn't getting the treatment that he needed in hospital, which would ultimately save his life, but he would have medical eyes on him. He would have access to Indigenous services that could honor and respect his culture, and somebody to look out for him. I unfortunately don't know what happened with that patient, but those are the kinds of things as APNs we're able to provide. Yes, this person wasn't interested in the clinical plan that the hospital had for him, but there are Indigenous medical services that can meet some of his needs somehow.
I'm not sure if we're speaking of the same patient, but something popped into my mind as you were speaking. It could be, could not be. But going back to people when we were kind of discussing earlier, who are apprehensive about accessing care. It might be the same person. Well, he was at the hospital. I built a rapport with him, and so did you. And when he was frequently coming into the hospital, and he was relatively fearful and apprehensive. But as I built a rapport, he got more comfortable, and he'd come down to our office, and be like, "Hey, Jess, I'm back. Have a little seat." And I think that made him feel more comfortable. So every time he was admitted, he would notify us APNs, and we'd come see him, and/or he would come see us if he was well enough to make it to our office.
Great.
Mm-hmm. Yeah.
Okay, awesome. So, follow up from Megan. Do you think this fear of self-identification that we were talking about before would also apply in a retrospective survey? So the PREM survey that she was talking about are done over the phone after the care encounter. What is your guys' response to that?
Well, I mean, I think in retrospect, it's hard to know, but the patient might feel more comfortable to have that follow up to say, you know what, I didn't feel safe to self-identify, and I mean, I left the hospital 8 months ago, and now I feel okay to say it because of this survey. But it might be a good opportunity for people to say, you're right, I didn't feel safe and I thought I would be treated differently, or whatever the rationale was for not wanting to disclose.
So that retrospective aspect will almost provide like a safety buffer, so to speak. Cool. Okay, do you guys have anything else to add to that? Sorry, didn't mean to cut you off.
Should we move on to the next slide?
We could move on to the next slide.
Oh, sure. Okay. Forgot about the slide.
That was a
big question. Yeah.
Very good question. Thank you.
To anybody we didn't get to, we'll pop back around. We've only got a couple more slides, and we'll pop back around to your question.
That was a good question, though.
Yeah, that was really great.
Yeah, I hope we answered it
Yeah.
sufficiently for you.
Sorry, we're just having some technical difficulties, so just bear with us for a moment.
Okay, we should be okay.
Okay.
So let's proceed.
So,
I guess I could start with this guy, connection before content, we like to say, which is just meaning, like, make a connection. I mean, I know in healthcare staff, they only have a certain amount of time with their patient. But we're saying, you know, to make because I mean, the patient might feel a little bit apprehensive to even be there in the first place, possibly fearful as well. So if you just make that connection, like maybe it could be as simple as saying, introducing yourself and sharing your own heritage, sharing where you're from, maybe asking where they are from, how they are feeling, instead of just like instantly coming in as healthcare staff and bang, 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 doing what you need to do. We suggest take a couple extra minutes for your patient just to be like, how are you doing? How are you feeling? Where are you from? Again, it might only take 2 extra minutes out of your day, but it will make a world of difference for them, I believe. If you guys want to elaborate on that.
Yeah, and you know, I think it was yesterday we received feedback from a unit, and the feedback we received is that in order to make that connection, there's always been that question of asking a patient what their ethnicity is, and it was always like a hard issue or a hard question to ask. And what we received was that, you know, what the thing to do is if you want to make that connection, and you might want to find out if the patient is First Nations, is ask them if they're comfortable with receiving spiritual or cultural support, and what would that look like. And so that's a starting point to make that connection before the content.
Yeah, that's a good point too.
Yeah, and I think with this, with this slide, I mean, we work in acute care settings. They're very fast-paced. Sometimes the people that we work with are very, very ill, and so it's a challenge. Acute care is busy. There's a lot of people who need hospital care. There's a lot of pressure on the staff, and so sometimes taking that extra minute or two seems like maybe daunting for the staff member, but it can be as easy as just coming in and saying, I'm just going to take your blood pressure. How are you doing today? And oh, where are you from? And just, kind of integrating the rapport building into the task somehow.
Yeah.
Yeah. And I think that would put anybody at ease.
Seems
from-
like good practice regardless, right?
Yeah.
Mm.
So Vancouver Coastal Health now has an Indigenous cultural safety policy,
Which
which
we were
we
talking
were
about.
we were
Yeah.
already talking
Yeah.
about.
Yeah.
And I mean, and to simplify it, I mean, there's really three basic concepts, and there they are right there. Welcoming and acknowledgement of the lands, which you did when we opened up this.
Mhm.
So like the land acknowledgement, again, usually happens when we open up either a meeting or a conference, something like that. Even at my daughter's elementary school, she's one of a few Indigenous kids there. She was asked to do a land acknowledgement at her assembly. So it's not just happening within healthcare, it's happening in other places as well. And then the second piece of our policy is inclusion of Indigenous knowledge and expertise in all levels of healthcare.
Okay.
And number three
Great.
would be access to traditional medicines and ceremony, which again, we've actually kind of spoken to that already. Us as APNs, we have traditional medicines in our office now, in our office on site at VGH. So, I mean, we can call in an elder if they would like that kind of ceremony. But as Colleen was saying earlier, there are certain, I mean, I've been taught how to do smudging, so I'm okay with that.
Mhm.
So if a patient wants to smudge with me, I'm more than happy to do so.
Mhm.
So, and if we don't have the medicines, we'll find a way to get them.
Yeah, access them. Great.
Okay.
Okay.
Well,
Back to our question. We
Back to
actually
the
do have some questions
Oh, okay.
in the
Great.
doc. So Benedict responded. That was in response to Megan's survey questions. So I think that Benedict was kind of did the patient feel listened to by healthcare professionals as being an important factor of kind of how they felt as they transitioned through emergency department. So
I
thank
see.
you very much for that, Benedict. Appreciate it. I think everybody here would agree with that. I totally do. The points that you brought forward, did the patient have the experience explained to them and have understanding, which I think, Denny, is kind of what you were talking about, right? Did the patient that's discharged understand what was happening?
mhm.
Yeah.
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 Okay. So then we have another general question. People from outside of the area, outside of Vancouver, Lower Mainland, they come into Vancouver for medical treatment, which happens often.
Very often.
Can they access APNs, and how does that work?
Absolutely. Well, I could start with that. We're all connected, like either Aboriginal patient navigators and or liaison. The term kind of can be either or.
Okay.
Within BC. We obviously identify as patient navigators, but we're all connected actually. So we've got all of our contact information. So say there is a patient traveling in from the Northern Health Authority. The Northern Health Authority APN may contact us and saying, we're having a patient coming to VGH. Could you please connect with so-and-so once they arrive?
Mm-hmm. Okay.
So we're in communication.
And
so each health, sorry to cut you off,
okay.
Glenn. So each health authority has the team of APNs, I suppose, or
APNs or
that-
APLs.
or APLs, right? Is that kind of how? So in the north they do, in Okanagan on the island. Is
Their
that
role
kind of
may, our
understanding?
roles do vary. I mean,
Mhm.
obviously we're speaking specifically to ours today.
Yeah.
Our roles may vary, but we are connected. We're all connected, and we are connected to the patients within the hospital system.
so they're connected through their acute care site.
Mm-hmm.
So, for example, sometimes we get referrals from Burnaby, which seems, if you're living in a remote community, it seems like Burnaby and Vancouver are quite close, but they're two different health authorities. And so sometimes I think both of you know that navigator by name.
Mhm.
So, and then we get, I was working with one of the patient navigators from the Williams Lake area, so central BC. So I think they're all attached to acute care sites, and then
Right.
we do get information from the community that somebody's coming down. But we work with people from all over. Like we
Okay.
get patients from the Yukon. I had one lady who was here from Ontario because she was only able to get the treatment that she needed at VGH. So yeah.
And as well, we're online too. As you can see, we've got our page up there too.
Mm.
So people, we have a lot of stuff is online actually. We've got a couple, I think another slide or two. We're also on YouTube and Facebook, I believe. So because there's so much stuff online, people have been able to find us just through online
Okay.
and access a program like that.
So my follow-up question to that is let's say for whatever reason a patient is coming into Vancouver and has not connected with their APL or their APN in their regional area, let's say.
Right.
For whatever reason. There's tons of reasons that perhaps a patient would have been missed. How would they connect with APNs once they come into the city, I suppose? That's my question. Do you know what I mean? If they don't have a previous connection with
Right.
their APL or their APN
Well,
at
first
home?
of all, they'd have to be entering into an acute site.
Okay.
And so they would just ask their patient care coordinator
Social worker.
Or
or
the
the
nurse.
social worker
Or the nurse, you said?
or the nurse to
Okay.
to get a connection with one of the navigators.
Okay.
But another way too is that if you know you're coming in for an appointment, you know you're coming in for
Treatment. That's something.
treatment at an acute site. Maybe have I know most First Nations communities have health centers, so have either your patient travel clerk or the patient even themselves can say, well, I'm going to be coming down just to let you know. I'm going to be in your area, and I would really appreciate a visit from one of the navigators. And so that's another way to get a referral too, right? Is through the First Nations health centers within the communities.
And we have
Good.
pamphlets as well floating around at the hospital. They're everywhere,
All over the
actually.
place.
Mm-hmm.
Okay.
And so when you say First Nations health centers, that's on reserve.
Okay.
Yes.
So, and we, as Jess was just saying, we have referral forms online. So families can fill that out. Your health benefits clerk can fill that out. And as you were also saying, we have a brochure, which we often send people the email link to that brochure, and then they can print it out themselves. And it outlines who we are, what areas we cover, what services you can access, which is basically all the services we've been talking about today.
In addition to that, most acute sites here in the Vancouver coastal health area and in Providence, we're becoming more paperless. And so referrals can now come through the Cerner's System of Transformation, so CST. So as Aboriginal patient navigators, we're going to be having a new domain specifically for the navigators. So if you're a healthcare provider, please understand that you can, in a little while, refer to our program to receive support and services for your patient through Cerner.
Great. Thanks, Timmy. Appreciate that.
Right now, Cerner is live at Lionsgate Hospital, and that's how, Denny, I think you get your referrals through Cerner?
The word's getting out there. So, I mean, I've had maybe a handful of referrals through Cerner, which is great. More would be better. But I understand, too, that there within our health authority, there a lot more other, more acute sites are going to be introduced into Cerner. And so it's something that,
So, sorry, Colleen.
It's okay. So eventually Cerner will be coming to VGH.
Great.
Yeah.
Okay. So my main question, kind of building off of this series of questions, is how would you guys suggest getting in contact with their local APNs or their APLs? Is there like a website specific for everybody in the, is there a listing somewhere that they can be like, here's where I live in this region, this is the website for these APNs or these APLs, or do you know what I mean? Like,
Well,
how do people in the communities connect, I guess?
Okay, I was going to say, well, we as staff have a list. And also, I have a master list.
Right.
And we communicate it through staff, and we don't pass it out publicly.
Sure.
But within our staff, we do. Again, I'd probably say by going to their health station.
Their health center.
Yeah.
So just to the nearest health center. Yeah, and I guess we'll probably try and make sure that we have the resources online that you guys are talking about, the referral forms and the brochures, so that if you're interested, on the Learning Circle website, you'll be able to download those after the session for anything, right? Or the links to do.
Yeah.
The links to do so.
Yeah,
Absolutely.
yeah. Cool.
So just to be clear, that the list that we have as APNs for the province of BC, that's an internal list, so it's not meant to be shared publicly. But you can also reach out directly to the acute care site, say, for example, Williams Lake Hospital. You could phone and just ask their reception, do you have an APN in your acute site, or wherever you may be, somewhere in the north or in the Kootenays or somewhere, just phone your acute hospital and find out if there's an APN. Yeah.
So we have a follow-up question from Emily. We have many patients who are flown out from Bella Bella to Vancouver hospitals. Just to clarify, can we call your team or send a referral with them if an APN connection would be helpful? Sometimes the person is unable to ask or consent for the referral. Are patients asked for these services unprompted, or do they have to specifically request it? So I guess two parts. As a health professional, just confirming, can they call your team and send a referral if an APN connection would be helpful? And then the second part, kind of, are patients asked about these services unprompted, especially if they're unable to to request it, I suppose.
I would say ideally we would like them to know whether consent to it. However, in the event where they cannot and they think that a service would be useful, we can certainly come in and just offer our services to them, and it's either going to be a yes or a no. So
right, and that part of that, I guess, would be the team that sent the patient out from Bella Bella sending that referral down
to us,
time,
and maybe
so
just
you guys know what's going on.
And maybe just notifying the patient is not aware of the referral. So we won't just go full force. We'll just be like, this is our service that we're offering. And I mean, just go from there.
Okay.
Sometimes it's the family who can provide consent. So a spouse or a loved one or somebody. We do get referrals often from Bella Bella or Bella Coola, and we've had patients airlifted down and they have not been able to provide consent. So sometimes what I'll do is I will go to the unit and introduce myself and obtain consent myself. Depending on how ill that person is, they may not be able to respond. So but
sorry if I can add too, so the sooner that the Aboriginal patient navigator is involved within the patient's healthcare in the acute site, the better it is for the team, the patient, and the team, the community team, when they return home.
And just dovetailing off of that, so just because of how busy the hospital gets and how busy we get, sometimes we get day before discharge referrals or day of discharge referrals, and those can be a real challenge to try and set up service or provide resources. So yes,
and that's depending on the patient's needs when they return home to the community.
Absolutely,
because you have to identify that sometimes we don't really understand that some of the supports and services recommended for the patient at the time of discharge is not available in their area.
Absolutely.
So the more notice we get, the better it is to understand how we'll be able to link the patient to appropriate services.
Great.
At the time of discharge.
And then on the flip side of that, of course, is sometimes we do get involved with patient care early on, and it's almost too soon because that person is so ill and they're in the middle of a lot of what we call workups, that sometimes we get involved and we want to support and help, and it's not maybe the best timing. So there's a bit of an art to get the timing right, but at least if the patient, the family, and the unit are aware that we're available, we can always visit that patient when things have settled down a bit. And
well, then at least you guys are aware of what's happening, and you can proceed forward.
Exactly.
Knowing what's best for the patient, kind of coming to an agreement between all the parties involved, right?
Yes. Yeah.
Great. So we'll just take a couple seconds for anybody that has any questions, any other questions. I know we've been filling up the chat box quite a bit, but I'll give you a few moments to kind of repopulate that and go over some of the comments. Emily says, thank you. Great idea for the family partner / consent offers. And thank you for connecting with our Bella folks. Awesome, Emily. Megan says, thank you, Colleen, Jessica, and Denis. And Benedict confirmed that was in response to Megan's survey question. Thanks. Yeah, no problem, Benedict. I want to check in with our video conference crowd there. If you guys have any questions, can you hear us okay? Just give us one moment. We can't hear you now. Just 1 second. Okay.
Oh, there we go.
Try it again.
I guess.
Yeah.
Yeah, it's Faye Michelle, CHR for Bridge River. You kind of answered the question already of in terms of referrals from one hospital to another. Can the Aboriginal patient navigator from that hospital send a referral to the APN from, say, BC, Vancouver coastal health hospitals?
Yeah, so I mean, when in terms of Interior Health Authority, you may have community members entering into Royal Inland Hospital in Kamloops. We have been connected to, I believe it's Gloria Big Sorrel Horse. She's the Aboriginal patient liaison in Kamloops, I believe. And so whenever, she's contacted us several times on to provide supports and services for First Nations, Métis, or Inuit who would be leaving their health authority into ours. They'd notify us, and then we'd be on watch whenever they would arrive to our acute site. And if it is our acute site, great. If it's not, then say like a referral might come to us because the patient's entering into Vancouver, but there's two health authorities here, right? There's Providence Healthcare.
There's 3, but yeah.
There's 3. Providence Healthcare. Oh yeah, PHSA, Providence, and Vancouver Coastal Health. So we, if the patient's not coming into our acute site, we would then link the Aboriginal patient liaison and or the patient or representative from the rural community to the appropriate hospitals, like St. Paul's Hospital is Providence Healthcare. They have their own healthcare team, Urban Aboriginal. Is it Urban Aboriginal?
Urban Aboriginal Health, yeah. That's
Urban
their team.
Aboriginal Health. And with PHSA, it's the Children and Women's Hospital, and they have their own team as well. So we would help them if it's not us. If the patient's not entering into one of our acute sites in Vancouver Coastal Health, we would make sure to link the patient to one of the teams within the other 2 health authorities within our area.
Yeah, we would
it's
just
always a good idea then.
Yeah, we would just provide that information, maybe an email with a website link for the other 2 health authorities. Yeah.
Right.
So yes, absolutely.
Short
Send
answer,
referrals
yes.
in. Short answer, yes.
Awesome. Thank you. Thank you.
Thank you.
Okay, so we have another question from Megan. Is there any data that is collected around the services conducted by APLs or APNs? Do you track any metrics around number of services, type of services? I assume Megan's asking so that she could maybe access that data, I suppose, and just kind of see what goes on.
So, so for the ICS training, we have what we call pilot sites at VGH, and we do have a follow-up form for those sites. I don't believe that we use that form for the rest of VCH. So generally, no. For the pilot sites, yes. Yeah.
Okay. Awesome. So I'll let the chat box continue to populate here. I'll do my outro. I'll get it out of the way right now, so then we don't have to sit through my mumbling at the end. I just want to insert a couple plugs for some upcoming sessions. We've got next week we have the Gitsan Dementia Project that's going to come on and talk to us about their research. And then the following week we're going to hear from the Regional Health Survey team from the FNHA. And then following that, we actually have Lisa Boyvin's going to come in, and we're going to do a couple workshops. It'll be a different setting. It'll be a lot of fun. She's going to come in and talk to us a little bit about her art and the way that we can use art to illustrate resilience. So that should be tons of fun. Look out for those sessions on our website. Yeah, it doesn't look like we're getting any other questions. Faye, over to you guys. Do you have any other final questions before we kind of sign off here?
I just wanted to say that Gloria Big Sorrel Horse now works in Kelowna.
Okay.
Kelowna. Okay.
Okay.
Yeah, she's been there for quite a few months now.
Okay.
Okay.
Thank
Awesome.
So,
Yeah. Yeah. Thanks for clarifying that. Appreciate that. One more.
Thank you for everything.
Emily, do you have any advice for small hospitals programs? I imagine she's talking about rural programs looking to get an APN program started. Maybe something. I assume you're talking about Bella. I assume Emily's talking about Bella here, but any advice for how to do that at an institutional level?
I mean, I think you could reach out to the staff, maybe to a manager. Start with a manager, and say that this is a service that's available elsewhere. We need it here. How can we advocate to have that kind of role introduced into our service? And to talk about the benefits, and then maybe providing information like a link to this webinar or to other information about APN service and ICS service that's available elsewhere, to say this is needed.
So what's going on in communities otherwise.
Yeah.
Or even a link to like our webpage as well. Like this is what's happening in Vancouver. Even talk to one of us APNs, something like that. Connect to somebody from our Aboriginal health team just to be like, this is happening here. what would it look like there, kind of thing, and how can we make this happen? So ideally, there should be this service at every single little hospital.
Totally.
I believe.
Yeah, absolutely. Okay. Denny, did you have anything to add to that? Or?
No.
No? Good to go? Okay. Awesome. Well, thanks. And Emily says, thank you all for your knowledge and your time. Yeah, no worries. So yeah, I've already done my plug. So I just wanted to thank you all again very much. Denny, Jessica, Colleen, thanks very much for coming on and chatting with us today. Hi, Tsepka. And to everybody that was watching, I appreciate you guys joining us for the first session. Bye, Faye. We'll see you guys later. Yeah, I really appreciate you guys coming and joining us again for the fall. So I look forward to seeing you again in the next couple weeks. And until then, take care. Bye-bye.